So I'd like to introduce the concept of the shoulder girdle. If you're not familiar with it, the shoulder is not just this area. It is not just the ball and the socket. The shoulder is way more complex than that. It at least starts where the collarbone or clavicle meets the sternum. This is called the sternoclavicular joint. Then it runs across into where the collarbone or the clavicle meets this bony process called the acromion. You can see that this is the roof of the shoulder socket, and that arm runs back and attaches to what is very aptly named and often forgotten about and underappreciated, the shoulder blade or the scapula. We then have the formation of the socket formed by all of the structures of the shoulder blade. The arm that comes across, the acromion, the socket part of, we call it the glenoid of the shoulder blade, and then a little tiny finger-like projection that a lot of muscles can attach, or muscles attached to, that is also part of this structure. And then of course we have the ball and socket, the humerus sitting in this socket called the glenoid. And so you can see that there's a lot of moving parts. This is a joint, we need movement through there. This is a joint, we need movement through here. And this is a joint back through here where we need movement. And of course, the glenohumeral joint, we need movement. If we have dysfunction at any of those areas, which is almost a guarantee, we end up with problems. And that's not to mention the function of the neck, which plays a huge role in how all of this gets put together. So as you can see, this is an extremely complex joint, and this is just the simplified version. Because now, when we look into this, we have to include all of the muscles that attach into all of these different areas. We have the neck muscles that come across and can be tight and dysfunctional. We have muscles that attach to the ribs and the collarbone that can pull us in different directions. We have a couple of key muscles that attach to this finger-like projection that comes from the back of the shoulder blade. And when those are tight or dysfunctional, we run into problems. We have muscles that attach from the side of the shoulder blade into the ribs and can cause issues. And of course, we have all muscles that need to be strong that oftentimes are not, that attach to these different structures. So we have to find a balance that where we optimize muscles that need to be strong and we work on soft tissue muscles that are pulling us in the wrong direction, and it's the balance that we need to start and understand. The key point is to understand how complex this whole structure is when we look at the shoulder blade and all the attachments in between, the collarbone, the neck, and then of course the shoulder socket itself. The complexity is up for us to help you with, but you have to understand how important it is to put everything together. So in the context of this complex shoulder girdle, we know it's not just the shoulder, this is not just the area, it's the shoulder girdle, it's all of these structures that work together and all the muscle attachments in between. Rotator cuff problems are a very, very common presentation. Rotator cuff problems to me would be akin to being on a motorbike that you just drove down a gravel road and then you hit freezing ice and all of a sudden you have a big wipeout. There has been a prelude, there's been foreseeable problems that have been happening all along, and eventually that rotator cuff will tear. Now there are rare instances, or there are some instances where the rotator cuff tears from a single injury. Typically the process and the problem is a long-standing progressive worsening of a condition that eventually results in one of a few different types of problems or pathologies. And I'm going to introduce a few of those different problems. I'm going to use the supraspinatus tendon, which is one of the rotator cuff. The rotator cuff is a group of muscles that help stabilize the shoulder and help do certain movements. They do external rotation or turning outwards of the shoulder, they do internal rotation, and they do movements out to the side, which we call abduction. Those are the main movements, and there are combined movements, obviously. The supraspinatus, the one that does this, is typically a common one that gets injured. That supraspinatus tendon attaches to our shoulder blade, again a common and underlooked part of this whole shoulder girdle, runs underneath here and is very prone to impingement or chronic wearing, and attaches to the side of the shoulder and does this for the shoulder movement. And we can imagine that when we get overhead, here we are impinging. If we have any level of dysfunction or mismatch of how that shoulder sits, So if this shoulder blade is sitting more forward than it should, we're going to be a lot more prone to impinge and wear this out. So that rotator cuff over time can wear down. Sometimes we'll see partial tearing. That rotator cuff sits underneath, and after impingement, we see that there is some tearing through there. So a partial tear might look like this. And that can progress to where we have a full thickness tear, where it is all the way through. This would be called a full thickness incomplete tear. And eventually this might pull completely apart where it's a full thickness complete tear. And now that tendon has nowhere to attach. This part is through here, and this part is stuck up here. So that's the natural progression. That's a single rotator cuff tear. People can overcome those and they can rehab and live a normal life, or essentially a normal life. However, there are essentially there are 4 major rotator cuffs, 4.5, but we can get more than one torn. Our goal is to prevent tears from happening initially. If there are tears present, we want to prevent them from worsening or reduce the risk of them worsening. And then if they're fully, completely torn, we want to assess how someone can function with that, how they can, do their daily living, their daily activities, and assess if they're able to continue on with the current path or whether or not they're the type of person who may need surgery. So what we might have is when we're assessing our patients, we're going to check your strength. We're going to assess the rotator cuff. So push out against me and meet my resistance. Push in against me and meet my resistance. And so we're going to do some different maneuvers and measurements to check your strength. So we're going to assess whether or not you have significant areas of weakness, and we're going to relate that to any imaging that you may or may not have had. If you have not had imaging, for example, an ultrasound or x-rays, we're going to look whether or not that's appropriate for you and order those, or assess previous imaging that may have been done and see if it makes sense with how we're evaluating you, seeing if the findings that they find on ultrasound are relevant to the way we assess you. Sometimes we find out that actually the imaging doesn't fit with your picture, and it can be hard. Just as mistakes can be made on assessing people, mistakes can be made on imaging. So we always want to make sure that the imaging fits with your own physical exam findings. So that's how we're evaluating things. So we're looking at the shoulder in the context of you, we're looking at the problems in the context of you, and making sure everything fits. And then we're trying to decide on what types of management strategies we have. So of course, as with our entire goal, and I'm sure your entire goal as well, we always want to intervene early. We want to prevent things from getting worse at the earliest stage possible. Prior to developing any potential tears, one of the dysfunctional things that we can see happen is that the tendon can get thickened, it can get unhappy, essentially. So the muscle fibers, the way they align, they can get disorganized, and that tendon becomes thickened. Again, that can be from that, and typically from that chronic impingement, anything that's impinging here, or anything that's stretching it. So if that tendon is getting stretched, for example, the shoulder blade is getting rotated forward, this tendon gets pulled and stretched, just like this elastic band. If I stretch this and continue to do this, and I rotate it through here, and I do this up here, I'm not only stretching it, but I'm impinging it. So we're going to have that goal as a team-based approach to reduce any factors that can lead to this impingement, but also improve the way the shoulder functions, the way it sits together, so that this tendon is not being pinched, it's not being made unhappy. And if we can catch it at that stage where it's just thickened, that's the ideal situation. If it becomes where you have already had some tearing, we can work with that and try to prevent things from getting worse. That's our entire goal here, is to optimize how the shoulder all works together, avoid any damage or any further damage. We're trying to make your shoulder better. We are bringing our expertise to you, a team-based approach, so that we can help you identify dysfunctional tight muscles, dysfunctional weak muscles, help you identify a plan that puts it all together. That might be an individual plan, that might be a group-based strengthening plan with individual components where we're working on that soft tissue. We're trying to develop the right plan for you and work with you and your needs and your support requirements. What we do want to look at is that if you are not progressing as we plan, and that does happen, we do anticipate that sometimes things won't go perfectly, we know that there are other steps that we can take. Occasionally individuals will need a cortisone injection. That injection might happen to the little fluid-filled sac called the bursa that sits underneath this region. Occasionally that needs to be settled down if it's inflamed, if it's impinged and pinched. You can imagine that this might irritate any structures underneath, and so sometimes the little fluid-filled sac that sits under there needs a cortisone injection. Sometimes we may need to do a cortisone injection to the shoulder joint itself. So we're using those tools available to us when they fit your requirements. We're not just doing that as our main treatment plan. If we do that, we failed you. We will use it when the time is right, when it's needed on your individual plan. As we've discussed, the shoulder is the most complex joint in the body. Again, that's my opinion. It's also why I love the shoulder, because when we can address all the issues, when we can get that shoulder improved, that function improved, people tend to do very well and are very happy. Of course, there are occasions where that doesn't work and where someone needs to see a surgeon for evaluation. The reality is that's a fairly small percentage of the people, and our goal is to make sure that by the time you see a surgeon, if you need to see a surgeon, that everything is been done that needs to be